behavioranalytics.org. And now I'll turn it over to our presenter, Janice Meinert.
Thanks, Kayla. Good morning, everyone. Thank you for joining us this morning. I wish we were doing this in person, but unfortunately, circumstances are still not allowing that to happen. So we will do our best in conveying the information that I hope will be helpful to you by way of the webinar. So let me just start with a little bit about the Pennsylvania Health Law Project. For folks there at the Alliance who may not be familiar with our organization, know who we are and what we do and how we can be a resource to the families that you work with. So the Pennsylvania Health Law Project is a statewide nonprofit law firm, and our work focuses on helping people access publicly funded healthcare programs and access services through those programs. So when we talk about publicly funded healthcare coverage, we're primarily talking about Medicaid, or what we often call medical assistance in Pennsylvania, CHIP, the Children's Health Insurance Program, to some extent Medicare, and in particular Medicare for low-income individuals, the Medicaid home and community-based waiver programs. And so we help folks with both eligibility for those programs as well as access to services in those programs. And in particular, we help people with denials of services. So as we talk today about specifically intensive behavioral health services, these services will require prior authorization from the Medicaid behavioral health managed care plans, just as the BHRS, the Wraparound services did. And so how services get prescribed may not necessarily be exactly how they get approved for kids. So when that happens, then the kids, the families are entitled to a written notice, and they're entitled to appeal rights, entitled to file a grievance. Beyond the grievance, they're entitled to file an external grievance and a fair hearing. And those are the kinds of things that we can help people with in actually advising them through that appeal process. And we can also actually represent families in that appeal process. The primary way folks get to us is through our helpline, and you see that number on your slide there. Our helpline operates Monday, Wednesday, Friday from 8 a.m. until 8 p.m. So those are the only times that people can call and either get through directly to our intake paralegal or generally leave a message. And then one of the case handlers will return those calls, through the course of the day and beyond, depending on the volume of the calls. Anybody can call our helpline. So, all of you certainly can call with any questions generally or on behalf of an individual, child and family that you're working with. And certainly the family members themselves can call us. So if you have any particular questions about our work, and in particular our individual client work, please feel free to, enter those in the Q&A box as well, and glad to answer those for you. And just to go back to the first slide, folks have my direct phone number and my email. So also don't hesitate to use that to reach out to me, about the Health Law Project in general, and certainly about any questions you might have that we don't get to today in the webinar. So let's talk about IBHS, or Intensive Behavioral Health Services. These are new services that are in regulation, and as of October of 2019, after 90 days, those services are, officially in place. So that happened around January 17th of this year. The IBHS services over the course of this year, up until July 17th of 2021, are replacing the behavioral health rehabilitation services, or what a lot of folks know as wraparound services. So come January 17th of 2021, the wraparound services, the behavioral health rehabilitation services, as we know them, will no longer exist. And providers who might currently be offering the BHRS services, if they are not licensed by January 17th of 2021 to provide the IBHS services, then they won't be, providing either, because the BHRS, the wraparound services, as we know them, and you're going to see as we go through this, that there are certainly similarities between what's provided, what's offered through IBHS versus the BHRS. But the BHRS, as we know them now, will be gone by January of next year. They will replace the wraparound services. Okay. So we covered some of these. One of the things I'd encourage families now, and encourage you perhaps to be talking with any of your families currently receiving wraparound services, is, to be asking their providers, are they licensed yet to provide the IBHS services? If not, are they in the transition process? Are they expecting to get licensed by the state? And specifically, when I say the state, I mean the Department of Human Services Office of Mental Health and Substance Abuse Services, OMSAS. And to be asking, what will this mean for their child? What will the transition, if their provider is transitioning to the IBHS, what will that mean for them? Because again, all providers who want to offer the IBHS, must be licensed by OMSAS, even if they aren't providing services to Medicaid recipients, and perhaps, providing services only, to people with commercial insurance, which is, generally not the case. Okay. So the state has a Human Services Directory website. And so I looked at that yesterday to get a sense of, how many providers currently are licensed in Allegheny County. And there are 15 licensed IBHS providers, assuming that website is fairly current and up to date. As of just yesterday, there were, 15 providers with a total of 32 sites, with Western Psych, Presley Ridge, and Wesley Family Services, each having, several locations, which is why you see, 15 providers, but actually 32 sites. Any provider who provides services in more than one location has to have each of those locations licensed by OMSAS. So, and at the end of towards the end of the presentation, I have the link to the state's Human Services Directory, where, anybody interested can go in and, just kind of follow, even in terms of, helping families figure out, is their current BHRS provider licensed yet as IBHS, that the Human Services Directory can, tell you whether or not that provider is already licensed. Okay, so what's going to be a part of the IBHS? So very similar to the BHRS, to the wraparound services. These are services that will support children, youth, and young adults, and that's how the state refers to them, up to the age of 21 with mental, emotional, and behavioral health needs. The services, again, as was the case and still is the case with wraparound, can be provided in the child's home, in the school, in some other community setting. And then there are 3 categories of services that kids could receive. There's individual services for one child. There is ABA, Applied Behavioral Analysis, which is actually a specific behavioral approach, but clinicians can specifically prescribe ABA, and then within ABA there are different levels of treatment and professionals that provide those services, and we're going to walk through those. And then kids also can receive group services provided to multiple children in a specific setting, generally in a community-based setting, including perhaps in schools. Okay. So I'm going to start with the ABA, with the Applied Behavioral Analysis first, and separate that out a bit from the individual and the group services, just because there are some differences around staffing criteria, around time frames that are different with the ABA as opposed to the individual services and the group services. So under BHRS, for starters, BHRS was never, Behavioral Health Rehabilitation Services, or Wraparound, were never services that were in regulation the way IBHS now is. So the BHRS was, the rules around the program, all existed in policies and in medical assistance bulletins, in the agreement, the Behavioral Health Managed Care Agreement between the state and the managed care plans, but the services themselves were never in regulations. These IBHS these are now regulated services. And under BHRS, ABA, itself was not, a distinct service. Generally it was a service provided, by a TSS or under the direction of a BSC, a behavioral specialist consultant. But the ABA in and of itself, was not a specific, and a distinct service. It is now under IBHS and governed by the regulations. And we're going to talk a lot today, about what's in the regulations, because in all honesty, that's really what we know at this point. These, services are starting to occur, but, they're really not full-fledged by any means at this point. And so in terms of, families, real and on-the-ground experiences with these services, we certainly at the Health Law Project are not getting those phone calls. So we're going to talk a lot about what the regulations say, as opposed to, how's this really playing out for kids and families and providers, because we're just really not there yet. Okay, so how does a child get, ABA under the intensive behavioral health services? Well, for starters, children do not have to have an autism diagnosis. Perhaps over time, we'll see that a vast majority of kids getting prescribed ABA services and receiving them do have an autism diagnosis, but they do not, that's not required in the regulations. They have to have a behavioral health diagnosis, but it does not have to be an autism diagnosis. So there's 3 steps to the process, and these same 3 steps also apply to obtaining the individual services and the group services, and you'll see those later as we talk about those, but the steps themselves are the same. First, there needs to be a written order done. Following the written order, an assessment has to be done, which is much more comprehensive and detailed than what happens at the written order level. And then an individual treatment plan for that child has to be developed. And And then all of those things together, often combined with a plan of care, gets submitted to the state, or in most cases to the behavioral health managed care plans. In Allegheny County, of course, that's community care behavioral health, for them to either approve or deny the services. So let's talk about, what has to happen with each of these steps. So the written order, who can do the written order? Licensed physician, licensed psychologist, a certified registered nurse practitioner, an other licensed professional whose scope of practice includes the diagnosis and treatment of behavioral health disorders and the prescribing of behavioral health services, including IBHS. So if a family went to see take their child to a private psychiatrist and that particular psychiatrist wasn't even familiar with IBHS, then they clearly really couldn't do the written order if they're not even familiar with what the services are and how the services are provided or what they're used for. But that's the scope of the clinicians who can do the written order. ABA can only be prescribed, as I said, if an individual has a behavioral health disorder in the DSM, the Diagnostic and Statistical Manual of Mental Disorders. I think the current version is the DSM-5, I believe, or the ICD, the International Classifications of Diseases. That written order must be done within 12 months prior to the initiation of ABA services. So in effect, that's saying to me that a written order is good for 12 months. And a face-to-face interaction with the prescriber and the child, and in all likelihood, the family as well, has to occur. So again, keeping in mind, we're now dealing, of course, with a whole lot of limits of COVID. There could be some exceptions to that, but generally speaking, the regulations require that, the clinician who's doing the written order, is meeting face-to-face with the individual. And in all likelihood, this would happen, in an office-based setting. Okay. The written order has to include some very specific information. And again, this is language straight out of the regulations. The clinical information supporting the need for the ABA. So what's the child's diagnosis or diagnoses? What are the problem behaviors or the skill deficits? What is it that we're trying to address that the clinician, the prescriber, believes, can be addressed by the use of ABA services? The written order needs to include the maximum hours of each type of ABA services per month, not per week, which is often the case with BHRS services. They are to be prescribed per month, and a maximum number. So, and then how many hours exactly and of each type service gets fleshed out in step 2 in the assessment. But the prescriber is, to have a sense and indicate maximum hours of each type. And we'll talk about the different types of ABA services. The settings where the ABA is to be provided. So, and being specific, X hours a month in school, X hours a month, in the home and community, whatever it might be, the settings where these services appear to be needed the most should be in the written order. And then the level of goal achievement, at which point the services can be either reduced, titrated, working towards, perhaps ultimately discharge from the services. So the written order should include, starting kind of with what is the need, what are the behaviors, what are the issues or the skill deficits, and then what are we looking for in terms of improvement or growth or change such that we would then expect the child to need, less of these services or no services, at least, these particular IBHS services, and perhaps some other type of outpatient service. Okay, so once the written order is done, then an assessment needs to occur. Again, might the clinician who does the written order also be the clinician who does the assessment? Maybe, I'm thinking not, but again, this is still just all developing and playing out. So we don't know for certain. I suspect it will probably be two different clinicians, one who does the written assessment and then a different one who does the assessment. In part because the assessment has to be completed in the home or in the community or both, especially depending on, where the need is and what's in the written order. So if services have been prescribed in the written order for both, in school, for example, and at home, then the assessment really should be taking place in both of those settings, and likely occur, in over, more than just one interaction with the child and with the family. The assessment has to be completed within 30 days of the initiation of the services. So the assessment itself is, only good for, for 30 days. When we're talking about prescribing ABA services, the assessment has to be done by a clinician that's qualified to provide one of the two types of the ABA services, the Behavior Analytic Services or the Behavioral Consultation for ABA services. And we're going to get to those screens that talk about, well, what are the qualifications of those two different types of clinicians. But those are the only, they have to be at least as qualified as the clinicians who can provide behavior analytic and behavioral consultation specifically for ABA services. And then the assessment itself needs to contain a whole lot of information. And again, this is language right out of the regulations, and it's very detailed. And so the expectation clearly, by the state, by the regulators, is that the assessment will be, very thorough, very comprehensive, strengths and needs across, developmental and behavioral domains of the youth, strengths and needs of the family, any existing, supports or needed supports, clinical information, including, history of any treatment. Has this child received any treatment, any prior diagnoses, medical, developmental, family, education, very, very comprehensive. An adaptive skills assessment that is required when prescribing ABA services. And as we talk later on about the individual and group services, you'll see that piece doesn't apply there. But it is required when the prescriber has prescribed some type of ABA service. Compilation of data, identification and analysis of skill deficits, the targeted behaviors that are to be addressed in measurable terms. Right now, the child is tantruming, 6 times a day, and the average tantrum lasts, 12 minutes. So the goal is going to be obviously to reduce those, perhaps both in frequency and in duration. Those kinds of things should be included in the assessment. Cultural, language, communicative needs of the youth and family, a summary of treatment recommendations from other healthcare providers, from school when that's appropriate and kids are school age, other service providers, that potentially could include, folks at the Alliance for Infants. And then once that assessment is complete, then from the assessment and and the written order, then it is developed an individualized treatment plan. That the treatment plan has to be written within 45 days of initiation of services, based on the assessment. It has to include the recommendations by the prescriber, the one who did the written order. The recommendation, it needs to include goals and objectives. That recommendation that's in the treatment plan can't be requesting any more hours or any more services or any different service than what's in the written order. If the assessment determines that the child needs something additional in the way of type of treatment or more hours of some service that was prescribed in the written order, then the person doing the assessment needs to go back to the prescriber to have that conversation with them, based on this more thorough and more comprehensive assessment that's going to take longer, that's going to be more detailed, and more time spent with the child and family and other people involved in the child's life. Then, if that yields the sense that, this child needs even more than what was in the written order, they need to go back to the prescriber and have that discussion, and hopefully the prescriber agrees and modifies their written order. If what's being prescribed is the same, within the maximum prescribed by the clinician who did the written order, or anything less, then that's fine. There's no need to go back to the clinician who did the written order. So what type of, the treatment plan needs to detail the type of services, the number of hours of each type, again, measurable, long, intermediate, and short-term goals and objectives. Frequency of baseline behaviors, treatment plan to address those behaviors, skill deficits and frequency, and, that goals, and that are again, all measurable. Where is the child now in terms of skill deficits, in terms of behavioral issues, and what is it that, what are we working towards? And by way of increasing certain behaviors, perhaps decreasing others, increasing, skills that perhaps the child right now appears to not have. Okay. The individual treatment plan needs to include whether and how parent training, support, and participation is needed to achieve the goals. That's a really important piece, because those of you who were familiar with and worked with families whose kids received wraparound services will know that, kids could not receive, with the exception of in school, but kids, could not be receiving TSS, for example, therapeutic staff support services, in the child's home if the child's parent, wasn't there and really, participating, because the whole goal of those services was to transfer, the skills from the clinician to the parent, so that the parent then knew how to, engage, intervene, what steps to take based on the child and the behaviors. Here are the regulations are saying, the treatment plan needs to be clear about, is there parent education that might need to occur, and to what extent is the parent expected to be actually participating, actively in the child's treatment. The treatment plans should address the ABA interventions that are tailored to achieve the youth's goal. The regulations themselves don't dictate what type of, ABA interventions are used. That needs to be, spelled out in the treatment plan and determined by the person doing the assessment, perhaps, with, others that are already involved with the child. the settings where the services are to be provided, and again, specifically, the numbers of hours of each service and in each setting. A safety plan, a crisis plan, a crisis intervention plan, and a transition plan, transitioning to a lesser level of care. The individual treatment plan, of course, should be developed with the youth to the extent that's, feasible based on the youth's age and, and other issues perhaps that are, developmentally and otherwise that might be occurring with the youth. And of course, the family. Families should always have copies of that individual treatment plan. Over the many years that I've done this work, there were too many times when I talked to families and asked them, what's in the child's treatment plan, or can you get me a copy of the treatment plan? And the family didn't have it. That should never occur. It's the treatment plan for their child that in all likelihood involves them and their family, certainly involves them to the extent that this is their child. Families should always have a current copy and should have been actively involved. There shouldn't be anything on that treatment plan, whether it's in terms of the goals, the objectives, the hours, and where they're the services and how many hours and where they're being received, the crisis plan. Nothing in that treatment plan should be a surprise to the parents. They should have been active in developing that. And then the treatment plan itself that needs to be reviewed at least every 6 months. And again, that happen in a clinician's office that they then, mail to the family. That should be happening, with the family. They should be actively involved in the development and the review and any changes and update to the individual treatment plan. Okay, so once the written order, the assessment, and the individual treatment plan are completed, in the case of Allegheny County, then they're all submitted to Community Care Behavioral Health, to CCBH, because again, these services certainly require prior authorization that the plan ultimately decides. In the case of kids who are not in the managed care system, kids who are in the HIP program, the Health Insurance Premium Payment Program, then the request will be going directly to the state, to OMSAS for approval. If services are not approved exactly as requested and detailed in both the assessment and the child's individual treatment plan, then families must be notified in writing. There needs to be a reason for why the services were not approved as prescribed. And that reason should always say more than, we determined they weren't medically necessary, period. Those expectations from those plans and from the state is that there is more detail about why the services are not being approved as prescribed. And then, as I mentioned earlier, families again will have the appeal rights, the same appeal rights they have with any Medicaid service denial, same appeal rights that they have right now with the wraparound services. They have a right to file the grievance. If they still don't have a satisfactory outcome at the grievance, they have a right to appeal beyond that to both the external grievance and the fair hearing. The Pennsylvania Health Law Project's helpline number is on all of those denial notices, as is the local legal aid office. In Allegheny County, that would be Neighborhood Legal Services. So in terms of families' appeal rights with IBHS, nothing's different. They have the exact same appeal rights that they have now, with wraparound services. Okay, and then as I said, there are different types of ABA services. And again, going back to the written order, the prescriber who does that written order indicating that they believe what this child needs and would benefit from, is our ABA services. They need to be specific about, well, what types of ABA services? Does this child need behavior analytic services? And if so, how much, how many hours a month? And again, remembering services are prescribed per month, not per week, and a maximum amount, at least at the written order stage. Does the child require behavior consultation, assistance behavioral consultation, and or behavioral health technician? And then, the regulations, talk about, what these services broadly entail, and who can provide them. So I think, again, what does this really look like on the ground? What should be my expectations if I'm a parent of a child who's getting, ABA services, and specifically, say, behavior analytic services? We don't know yet. We don't know exactly what this is going to look like on the ground, because again, these services are still just being launched. But this is what the regulation tells us about what the behavior analyst it should be doing, and what's the qualifications. What do the qualifications have to be of the person doing the behavior analytic services? So this is the clinician that's providing the directions of services, development and revision, and oversight of the individual treatment plan, in consultation with the treatment team. The treatment team perhaps being, other, ABA services. The behavior analyst does a functional analysis, and that's one of the key differences between behavioral consultation services and behavior analytic services. The behavior analytic services includes that clinician doing a functional analysis with the child. Who can provide these services? A BCBA, a person board certified as a behavior analyst, who's also a licensed behavioral specialist, or licensed psychologist, licensed professional counselor, marriage and family therapist, clinical social worker, or certified registered nurse practitioner. So the person has to have, their BCBA. They have to be board certified as a behavior analyst, and then also be any one of, or more of, of the below criteria, professionals. The behavioral consultation services, again, basically the same as the behavior analytic, except it does not include a functional analysis, and the staff qualifications to provide these services are not exactly the same. So I would suspect, when I think about how these, again, services will play out, in reality, I would suspect that that a child probably won't have both behavioral analytic services and behavioral consultation services at the same time, or perhaps the behavioral analytic services will be more time limited because the child needs a functional behavioral analysis. And then perhaps once that occurs, then, the services might just be behavioral consultation. But again, that's just my best, my best educated guess at this point. We really don't know yet how this is playing out on the ground. And so, the staff qualifications for behavioral consultation for ABA does not have to be a board certified behavioral analysis, but must be, one of the below, the board certified assistant behavior analyst, or 1 year of full-time provision of ABA plus 12 ABA college credits, obviously have to be documented, or 1 year full-time provision of ABA under the supervision of a BCBA and 40 hours of ABA training approved by the state of the Behavior Analyst Certification Board. Okay. The third type of ABA services, assistant behavioral consultation, as the name implies, a person who assists the clinician who's either providing the behavior analytic services or the behavioral consultation. And then, you see the list there in front of you on the screen about, so what is the staff qualifications? Who are the clinical folks out there who can provide assistant behavioral consultation? And I'm not going to read through all of those with you. And then the fourth type of ABA services that can be prescribed is called the behavioral health technician. And this position seems to replace what we know to be now the TSS services, the therapeutic staff support in Wraparound in BHRS. And then the staff qualifications, again, these are all straight from the regulation. Who can provide the behavioral health technician services need to have, one of, the 5 below credentials in order to be providing the child with ABA behavioral health technician services. Okay, so I think this might be a good natural breaking point before I move on to talk about the individual and group services. I think I'll pause here, check in with Kayla, and see if we have any questions that have come in.
So far, no questions. Let me double check. Yep, no questions. So just a reminder to folks, if you have questions, you can put them into the Q&A box. That is about in the lower middle of the control panel at the bottom of your screen. Yeah, so no questions for now, Janice.
Okay, all right, great. Folks, don't hesitate. As our grade school teachers told us, there are no dumb questions. So, and some of this is just still, as I said, it's still evolving. This is still a learning process for all of us in terms of what these services are going to look like. Okay, so let's talk about the individual and the group services in IBHS. Okay, so individual services, one-to-one services provided to youth with mental, emotional, and behavioral health needs in the home, school, and community. In that regard, again, similar to the wraparound services. And then what types of individual services could a child receive, or combination of behavioral consultation, mobile therapy, and the behavioral health technician. So these services look similar, certainly on the individual service side. Non-ABA services, looks similar to the wraparound, with, what we have now is the TSS being replaced by the BHT, the behavioral health technician. Group services, intensive therapeutic interactions provided, as the name implies, in a group format. So these services might be provided in schools, in daycare programs, in after-school programs, in a summer therapeutic, camp. So group services could include group and family psychotherapy. So the group could in fact be, the child and family. They could include psychoeducational group activities, the clinical direction of the group services. So that's, that's a billable service. The clinician who's providing the clinical direction of the group services. The creation, revision, and oversight of the individual treatment plan is all a component of the group services. Just because a child is prescribed and receiving group services, doesn't mean there's some group treatment plan. There isn't. Each child in that group would still have, their own goals, their own reasons for participating in this particular group. And so, each of those kids would have, their own individual treatment plan. And consultation with the treatment team. So whoever else might be providing services, as well as, that treatment team certainly includes families. It includes, it could include schools. It could potentially, include, folks like yourself working with families through the Alliance. Some examples of group services: PCIT, parent-child interaction therapy, grouped applied behavioral analysis, group ABA, school-based programs, after-school programs, and summer therapeutic activities programs. Folks, again, who are familiar with Wraparound will know that, with BHRS, that summer therapeutic activities program, sometimes just referred to as summer camp, it is a part of BHRS. It will also be a part of IBHS in the form of group services, and will get prescribed as a group service, specifically summer therapeutic activities program. Okay, so how do kids and families access the individual and group services? The same way, just some distinctions between the ABA and the individual and group services, but the same process. There needs to be a written order, a clinician who's qualified to write the written order. There needs to be an assessment following that written order, and then following that, the development of the child's ITP, the individual treatment plan. Who can do the written order? Very similar to who can, do the written order for the ABA, although again, in the case of ABA, depending on what's being prescribed, the person doing the written order has to have, certain credentialing that isn't necessarily required for the professional the clinician who's writing the order for the individual services or the group services. Again, it must be face-to-face interaction, must be done within 12 months of the initiation of, either the individual or the group services, and certainly both in any given child circumstance could be prescribed at the same time. It has to include the behavioral health diagnosis. The child has to have some type of behavioral health diagnosis to get these services. It needs to include, the IBHS services. What is it that the child's getting? Is it individual services? What type? Is it the mobile therapy? Is it behavioral health technician? Are group services perhaps also being prescribed? That all needs included in the written order. The clinical information to support the medical necessity, what's happening with the child, what are behaviors, what are skill deficits, what is it that is expected to be addressed by these services. And again, the written order includes the maximum number of hours of each service that's being prescribed per month. Again, that maximum number may not be exactly what is determined needed once the assessment is done and the individual treatment plan is developed. But the clinician, should be looking at, what are the child's issues, where are those issues playing out, and then talk about, each type of service and an expected maximum number of hours of each per month. Again, the settings where they're, to occur, measurements, what's kinds of, are goals with this child, and how will we know when the service is being prescribed can be reduced or changed, terminated altogether. And then following that written order, there's a clinician who needs to do the assessment. And is similar to what we know of the psychological evaluation in BHRS, but with BHRS, that assessment had to be done, will be done by a psychologist or a psychiatrist. There's a broader array of clinicians, who can the assessment for individual and the group services.
Hey, Janice. Janice, just cutting in, just letting you know, we're having a little trouble hearing you. Your sound is cutting in and out a little bit.
I did just get a flag come up on my screen saying that my internet service is, I don't even know what the word was, but yeah, so let me know. I'm not quite sure even what to do on my end, Kayla, but let me know if that's persisting.
Okay, we'll do it. I think, yeah, it may just be out of our control, so just keep doing what you're doing.
Okay, all right, but yeah, let me know if it's still a problem. So who can do the assessment for the individual and the group services? It has to be done by a professional qualified to provide either the behavioral consultation services or the mobile therapy for the individual services. For the assessment for group services, it has to be a graduate level professional who does that assessment. And for the individual services, the professional qualified to provide behavioral consultation or mobile therapy, we'll get to a slide in a minute that explains, what are the qualifications for those staff. The assessment has to be completed within 15 days of the initiation of services. That's a different time frame than there is for when ABA services are being prescribed. Okay. And again, the assessment includes, the really broad array of information and data that is similar to the assessment that has to occur when what's being prescribed is, the ABA services. Strengths, needs of the child, of the family, existing support, needed supports, formal and informal, the specific services, skills, supports, resources the youth needs to address, therapeutic needs, supports and resources that the parent or guardian might need, all the clinical information on the child, the family, medical information, developmental, educational, social, any trauma history, any other relevant clinical information, all should be a part of, this written assessment. The youth's level of developmental, cognitive, communicative, social, behavioral functioning across, all domains in the child's life. Again, cultural, language, communication needs or preferences of the youth and family, and summary of treatment recommendations from, healthcare providers and others working, with the child and family. So very similar kinds of requirements that need to be included with the assessment for individual services and group services as there are with the ABA services. Okay. And then again, in the individual treatment plan follows the written order and the assessment. Again, what's different here in part is that the time frame for ABA services, that individual treatment plan has to be developed within 45 days of the initiation of the services. In the case of individual services being prescribed or group services, that individual treatment plan has to be developed within 30 days of the initiation of the services. Excuse me. And again, what has to be included in the individual treatment plan? very detailed information. What services, type, amount, frequency, duration, settings, where the services are, going to occur, goals, objectives, interventions, time frame, expectations to complete each goal, the type of service, the number of hours of each service in each setting, again, whether and how parent participation is needed. I'm going to pause there for a drink. Again, a safety plan, a crisis plan. In the case of the group services, the individual treatment plan has to include goals and objectives, again, with definable and measurable outcomes, whether and how parent participation is needed, the structured therapeutic activities, community integration activities, individual interventions to address the therapeutic needs for youth to function in home, school, and community, timeframes, again, to complete each of these goals, settings where the group services might be provided, and the number of hours of group services to be provided. So, all of these things spelled out, in the individual treatment plan that, again, should be developed with the youth where appropriate, certainly with the family, and with, other key people in the child's life, especially in the case of school-age kids. If those services are going to happen in school, then it really should be including, teachers or somebody appropriate and involved with the child in the school setting. Okay. IBHS also includes evidence-based treatments that can be specifically prescribed and have to be prescribed in the case of each of these by a clinician who's qualified to prescribe, to deliver, to actually provide the services. That's the level the clinician has to be or above to prescribe these services. Right now, OMSAS, the state has identified 5 different evidence-based treatments that are appropriate with IBHS and can be prescribed. Certainly over time, there could be other types of evidence-based treatment, but for right now, these are the 5 types of therapies that can be prescribed within the context of individual or group services. Multisystemic therapy that's specific for problematic sexual behavior, multisystemic therapy, psychiatric, functional family therapy, and parent-child interaction therapy. So right now, these are the 5 types of evidence-based treatment that could be prescribed, and again, has to be prescribed by, a clinician who's, qualified to provide the EBT services. Okay, I'm going to pause here before we get into the last of this. Kayla, just to check in with you to see if there are any questions.
Yes, there are some questions. And just so you know, Janice, your sound is much better.
Good.
Okay, so Kelly asks, this is kind of a long question, but Kelly asks, I had a child on my caseload recently evaluated by a licensed psychologist. The evaluation report reads that the initial prescription is for a behavioral specialist consultant for 16 hours over 30 days to complete functional behavioral assessment, and then 3 hours per week of BSC/ABA for the remainder of the 26-week plan of care. The result of the SBA will be used to determine hours of therapeutic staff support needed. I was able to make a referral to an agency, and they said that they could provide BSC for the child and family. Will we continue to hear BSC/TSS for a while, or should we start hearing behavioral consultation, mobile therapist? behavioral health technician more. I have had a handful of children receive a diagnosis, and I have made referrals for them to get support through a licensed psychologist's recommendation, but I'm still seeing BSC and TSS a lot.
Well, certainly, I think we will continue to see that through the end of this year. We should be seeing less of it as the year progresses, because again, come January 17th of next year, 2021, the BHRS services are ending. And so only IBHS will be left standing at that point in time. So, right now you're possibly still seeing those services because the prescriber themselves and the team providing the services prescribed, perhaps they're not yet licensed as an IBHS provider, or it's possible they are licensed as an IBHS provider, but because up until last Friday, there was no formalized medical necessity criteria for all of these, for each of these services, it obviously made it kind of tricky to be prescribing them when the clinicians prescribing them did not have the really key piece, which was the medical necessity criteria for each of the services. So now that medical necessity criteria is finalized and it's out in bulletin form, that's, I think, can be a potential, big game changer here. But again, yes, so I think between now and December, January 17th being the last date, we should start to hear more about things like the behavioral health technician versus the TSS. And again, I encourage you to encourage families that you're working with who have kids that have been prescribed and are getting BHRS services to talk to their, prescriber. I understand these services are ending, and getting replaced by IBHS, and ask that provider and the prescriber, because who's providing the services is different than the clinician who's prescribing the services. Are you licensed to provide IBHS, or are you in the process of doing that? Because as we get closer to January of next year, I would think well before January, I'd want to know that information. If my child's working with a clinical team who come January, any one of those clinicians are not going to be qualified because people aren't getting grandfathered. I mean, they have to meet the criteria for these, these new service types. And if they're not going to be providing those services. So I would think that's really important information for families, especially, of course, if they're working with a clinical team or any individual clinician that they're really feeling good about and feel like they're really effective in working with their child. So good question.
Okay, and Janice, that was such a good answer that answered the other question that someone was asking. So yeah, so you answered all the questions.
All right, great. Thanks, Kayla. And thanks, Kelly. Okay, so, what else do we know at this point in time? Again, in this, we're in flux, and these, these services really are, we're going to be looking at a year from now when we have a better sense of how all of this is playing out. But what else do we still know at this point? The ISPT, the Interagency Service Planning Team meeting, that is a required part of BHRS, and perhaps some of you have even participated in those ISPT meetings. That is no longer a requirement with IBHS. Those meetings certainly can and should, when needed, occur. Anybody could request that meeting to occur. I think and each of the behavioral health plans, I don't know whether or not they'll be consistent about what they'll call it, a team meeting, a planning meeting, whatever they may call it. But that idea of the ISPT that had to occur before the request could even be made to the behavioral health managed care plan, that requirement no longer exists with IBHS. But again, planning meeting, team meeting, whatever you want to call them, those should still occur at whatever point, the family, the provider, the school, whoever it might be, feels that a meeting would be helpful to get the players together and communicate better and be on the same page. These services, of course, will still require prior authorization, just like the BHRS. And it looks like all three, the written order, the assessment, and the individual treatment plan, all have to be completed, developed, and then submitted to what will be, in most cases, in Allegheny County, community care behavioral health. The clinician who does the written order is the one who should help defend the prescription if the services are not approved as prescribed. Though, it doesn't have to be limited to the prescriber. So again, we have a written order done by one clinician, an assessment done by another, and then an individual treatment plan developed. All that gets submitted to the managed care plan. If the managed care plan does not approve the services and the hours, in the settings exactly as prescribed, then the parent's entitled to that written notice and entitled to an appeal. When we work with families on the appeals, one of the first things we ask them is the clinician who, wrote, what we will then, down the road be calling the written order, is that clinician willing to participate in the grievance and defend what they prescribed? That's always really important and really helpful to win those appeals. So that would be the first person I'd be looking to, is the clinician who did the written order. But again, it doesn't have to be limited to that person. The clinician who did the assessment might also be a really helpful person in trying to defend if the services are not approved as prescribed. Okay, what else do we know? Act 62 still applies in IBHS. So Act 62 is Pennsylvania's autism law that applies to commercial insurers. Generally, we're talking about, insurers, insurance that kids have through parents' employment. When that employer is based out of Pennsylvania, employs at least 50 people or more, then that insurance company is required to provide up to, and I think the dollar amount is up to around $38,000 a year in services, both behavioral health or physical health, as appropriate for the child with autism. That act still applies to IBHS, so nothing changes. Nothing changes about that. As I said earlier, a child with or without an autism diagnosis can be prescribed ABA services. Does not have to have an autism diagnosis, but does have to have a behavioral health diagnosis. Again, the written order should include a maximum number of hours of each service per month, per setting, if they're being prescribed in more than one setting, and should not include a range of hours. It should be one number per service, the maximum that the clinician thinks is necessary. And I think I touched on this earlier. If after the written order, the assessment happens. If that assessment determines that more hours, of a given service are needed, or perhaps even a different service than what was in the prescriber's written order, then that clinician who does the assessment needs to go back to the prescriber who did the written order and have a dialogue about that and make their case for the person doing the assessment, for why they think more hours or a different type of service should be provided. And then in the case of community care, when I went on their website recently to see what information, updated information they have about IBHS, they, on their provider page of their website, they've developed what they call, and I think it might be an existing form, but one they'll use with IBHS, a prescriber collaboration form. So it sounds like that form will be what the prescriber who does the written order, if they agree that something different or more services of a type they prescribed is really what the child needs, then it looks like they will complete this prescriber collaboration form, in essence, I guess, an addendum to their written order. But CCBH has a specific form that prescribers can use if they're making any changes to their written order. Okay, what else do we know? Services can actually begin once there's a written order and a treatment plan. Treatment plan not being the same thing as an individual treatment plan. So, and again, this is in the regulations. The part that is less than clear to me is, if it looks like the child really needs some immediate interventions before the assessment is even done and the individual treatment plan, the formal, so to speak, treatment plan is completed, the child could receive services just based on the written order and, a treatment plan that would be, much less, I would think, formal and involved than what the individual treatment plan is to look like. But again, it's not quite clear to me from the regulations, how that would occur. And I would think, again, these things are the pieces they're going to develop over time. The prescriber or the providers who, well, the prescribers and the providers of IBHS services are going to begin to learn, how does this play out in reality? Under what circumstance can a child start to get services before there's even an assessment and an individual treatment plan done, and who's providing them and how are they getting paid for them? Those are the devil in the details questions, and obviously important questions. But again, it's important, I think, for families to know that the regulations say that services can begin just with a written order and a treatment plan, and not, while waiting for the rest of the process to play out, so as not to be waiting and have the child with no services. Again, the assessment has to be done at least annually. The assessment itself doesn't have to be signed by the youth or family, but the individual treatment plan does. And again, of course, families should be heavily, actively involved in the development of a treatment plan and any revisions to the individual treatment plan, and should always have a copy and the most current, recent copy of the child's treatment plan. Again, the individual treatment plan assessment should be done at least annually, individual treatment plan updated at least every 6 months. If there's no progress on any of the goals in the treatment plan within 90 days, then a new assessment has to be done. And again, that's all spelled out in the regulations. Okay, what else do we know? That the behavioral health managed care plans, and they each may operate differently. There are certainly providers who, cross over into other counties, and therefore, depending on the counties, may be dealing with different behavioral health managed care plans. In the Southwest, community care is only in Allegheny County, and all those counties that touch Allegheny County have a different Medicaid behavioral health managed care plan. Those managed care plans, as I understand from them, were working collaboratively over the development of all of these of IBHS services, and are trying to be to have some consistency between them, so that providers aren't kind of pulling their hair out trying to remember what I have to do, what form or what things I have to do for this plan versus a different plan. But ultimately, there are things that the managed care plans will just, they'll determine what information, what forms, if they're using forms, et cetera. The regulations also say that only a licensed physician or a licensed psychologist can deny the services prescribed in the written order. So, the written order, the assessment, the individual treatment plan, all gets submitted to, most often will be the behavioral health managed care plan. If what's requested, if what's been prescribed is not approved exactly as prescribed, then the regulations say that it has to be a licensed physician or a licensed psychologist at the behavioral health managed care plan who denies the services. So it can't, even though the services themselves can be prescribed by, say, a licensed social worker, it can't be a licensed social worker on the other end at the managed care plan who makes the ultimate decision to, deny services as prescribed. It has to be a licensed physician or a licensed psychologist. In most cases, that licensed physician will likely be a psychiatrist, perhaps a developmental pediatrician. The regulations also allow for IBHS services to be provided to youth who are transitioning out of RTF, out of a residential treatment facility, to home, if the written order explains why both the RTF services that the child's still getting are needed in addition to the IBHS services. I thought this was a really good component in the regulations. I've worked with families, many families over the years, where kids are transitioning out of the RTF to go back home, and the transition was not a good one. There was not enough work being done in that child going from, the very structured therapeutic setting of the RTF back home. And so I thought it was really positive, and I suspect families who were involved in the development of these services were likely the strongest advocates for this, that in fact kids can be both of those services at the same time. Again, it's going to be incumbent on the clinician doing the written order to explain why, this child really and the family needs both for some, likely limited period of time. But I thought this was a really positive thing in the regulations. What else we know? The current BHRS providers, and I've said this many times already, that are not licensed as IBHS providers can still provide the BHRS, which is why we're still hearing VSC and TSS. They can still be providing those services until January 17, 2021, and then BHRS services are gone. And as I said, the medical necessity criteria for all the IBHS services, individual, group, ABA, they were just released in a bulletin form last Friday. So that's a very, very important piece of the puzzle that is now finalized. Okay, so what do we still don't know? Well, a million things, I'm sure, but some of them that came to my head, you know, will the new staff qualifications, you know, impact the number of available licensed IBHS providers? Many of you may know that, you know, kids are sometimes prescribed these services on the wraparound side and wait to get the services. That should not ever be happening for any Medicaid service. And yet we know that it has, and it continues to be a problem. So now these new services and the staff qualifications that are in regulations for the different types of services and the qualified clinicians who can provide them and prescribe them, is this going to enhance the numbers of qualified providers, or is it going to make it even harder to get IBHS services than it is currently for some families getting the BHRS services? We don't know. Are there going to be enough BCBAs to meet the need for the youth prescribed the ABA services? You know, we don't know. We hope so. We hope even as all of these, as the IBHS services were being developed, and especially specific to ABA services, that that providers, you know, were working with their staff, recruiting perhaps new BCBAs, working with staff to get their, you know, finish both the experience component or the training and the education component to become a board certified behavioral analyst. Are we going to have enough? We don't know. And will all of the current across the state, you know, BHRS providers, you know, by next January become licensed to provide IBHS? Again, we don't know, but for, you know, families currently getting those services, their kids getting those services, I'd certainly be asking the questions. Okay. And then the last page is just some resources. The state OMSAS has an website devoted just to IBHS information. There is a family fact sheet in there that it's just a couple pages long, gives some basics. That might be, you know, a helpful piece for folks at the Alliance to, you know, print off their website, assuming printing capabilities these days. I know we're all working in a different world now. You know, there's a, you know, a lengthy FAQ, frequently asked questions that the state keeps adding to, and it's broken up into segments, which is helpful to try to find a particular question and answer that you're looking for. The next resource is the one I referred to earlier. It's the State Human Services Directory. This is for, you know, a whole range of services that are provided through the state, through the Department of Human Services. And you know, you click on first the provider, the type of provider that you're looking for. You know, if you plug in IBHS, you know, you will see the, you know, and plug in Allegheny County, you'll see the list of, you know, the 32 licensed IBHS providers currently in Allegheny County. And then again, you know, whether it's kids now still getting BHRS or down the road, the IBHS services, families having difficulty accessing those services, families or kids whose kids are prescribed the services and are denied in part or in whole. They will find the Health Law Project's helpline number on that denial notice. Please encourage folks to call us, reach out to us to get advice on, you know, on an appeal and perhaps actual representation in the appeal. That's everything I have. I'm going to go back to Kayla again and see if there are any final questions on her end.
No, there are no more questions.
All right, great. Folks, you, as I said, you have my direct phone number. You have my email. If questions pop up, whether it's later today or 5 months from now, whenever it might be, please don't hesitate to reach out. Certainly as things evolve here, perhaps down the road, we'll be available to do, another training that will be, I think, perhaps more hands-on. This one, of course, was just much more technical because it's what we know now, and what we know now is primarily what's in the regulations. So thank you, everybody. I know you folks stay extremely busy. I have a dear friend who works for the Alliance, and doesn't matter when I ask her how's work, it is busy. I know you folks stay very busy and do lots of great work for families and young kids. So keep up that good work. I hope you're all managing okay in these rough, scary times. Thank you so much, everybody, for spending your time with us this morning, and don't hesitate to reach out. This was recorded this morning, and Megan, I'll be connecting with you to get you the recording. All right, thanks, folks. Enjoy the rest of your day. Stay well and stay safe. Thank you, Kayla. Can't do